Imagine for a second that the medication keeping you alive, literally the thing stopping your body from shutting down, might also be slowly stealing your eyesight. It's a terrifying trade-off, isn't it? You wake up one morning and there's a blur that wasn't there yesterday. Or maybe you're driving at night and the streetlights have these strange glowing halos around them. For people living with adrenal insufficiency, this isn't just a hypothetical nightmare. It's a daily background hum of anxiety. We're talking about the complicated relationship between long-term steroid use and our eyes, specifically the risk of cataracts and glaucoma. I'm Chloe, and today we are looking fear right in the face, but we're going to do it with facts, not panic.
And that distinction, facts versus panic, is crucial here, Chloe. Because when you rely on steroids for survival, you don't have the luxury of just stopping the medication to save your eyes. That's not an option. So we have to understand the nuance. I'm Alex, and I've been digging into the research on how steroids affect ocular health, specifically for the adrenal community.
So let's start with the elephant in the room. This fear isn't irrational, right? We hear steroids cause blindness, and it's hard not to spiral. Is that a fair assessment, or is it alarmist?
It is not irrational, but steroids cause blindness is a massive oversimplification that can actually be dangerous. The fear is valid because the biological link is real, but risk is not the same thing as inevitability. That's the headline here. Just because you take steroids doesn't mean you are guaranteed to lose your vision. However, the mechanisms, how the drug actually interacts with the eye, are well documented.
Okay, so let's break down that mechanism. What exactly is happening inside the eye when we introduce long-term corticosteroids?
There are two main bad actors we need to talk about: cataracts and glaucoma. They work very differently. Let's start with cataracts. A cataract is essentially a clouding of the eye's natural lens. Now, the National Eye Institute lists steroid use as a specific risk factor for cataracts. But here is the specific detail that matters. Steroids tend to cause a very specific type of cataract called a posterior subcapsular cataract.
Posterior subcapsular. That sounds very specific. How is that different from the cataracts my grandma got just from getting older?
Great question. Age-related cataracts often form in the center or the edges of the lens and grow slowly over years. Posterior subcapsular cataracts form at the back of the lens capsule, the part right in the path of light passing through to the retina. Because of that positioning, they tend to interfere with reading vision and create significant glare, especially at night, much faster than other types. So a patient on steroids might notice, hey, I can't drive at night anymore, sooner than someone with a typical age-related cataract.
And that glare. That's the halos people talk about, like seeing starbursts around headlights?
Exactly. And colors might look faded, but here's the silver lining, and it is a bright one. Cataracts are fixable. The National Eye Institute describes cataract surgery as highly effective and safe. It's one of the most common surgeries performed worldwide. So while a cataract is scary, it's rarely a permanent sentence of blindness, if treated.
Okay, so cataracts are the fixable problem, but then there's the other one, glaucoma. That feels heavier. Why is glaucoma the one that keeps people up at night?
Because glaucoma involves the optic nerve, and optic nerve damage is generally irreversible. Glaucoma is often, though not always, linked to high pressure inside the eye, known as intraocular pressure, or IOP. The Glaucoma Research Foundation explains that corticosteroids can actually impair the eye's drainage system. Imagine a sink where the faucet is running, but the drain is clogged with gunk. The water level rises. That's your eye pressure rising.
And if that pressure gets too high, it presses on the nerve?
Precisely. It compresses the optic nerve fibers, killing them off. And the terrifying part, the reason monitoring is non-negotiable, is that you usually cannot feel this pressure. You can walk around with dangerously high eye pressure and feel absolutely fine until you start losing peripheral vision. By the time you notice vision loss, the damage is done.
That is chilling. You can't feel it. So, does everyone on steroids get this high pressure? If I'm taking hydrocortisone for Addison's, am I definitely clogging that drain?
No, and this is where individual biology comes in. We have this concept called being a steroid responder. The Glaucoma Research Foundation notes that some people are genetically predisposed to have their eye pressure spike in response to steroids. Others can take massive doses and their pressure barely budges. You can't willpower your way out of being a responder. It's just your genetics. That's why you can't compare yourself to someone else in a support group. Their eyes are not your eyes.
This brings up a massive point of confusion in the chronic illness community, the difference between replacement steroids and high-dose steroids. I feel like we lump them all together, but surely taking 20 milligrams of hydrocortisone a day to replace what my body should make is different from taking 60 milligrams of prednisone for a flare-up of lupus.
It is completely different, and conflating the two causes so much unnecessary panic. In adrenal insufficiency, whether it's Addison's or SAI, the goal is physiologic replacement. We are trying to mimic the natural cortisol rhythm. The risk profile for replacement doses is generally lower than for pharmacologic anti-inflammatory doses. However, and this is a big however, it's not zero risk.
Why not? If it's just replacing natural levels, shouldn't the risk be the same as a healthy person?
In theory, yes, but in practice, dosing is rarely perfect. We have peaks and troughs. We have stress dosing for illness. We have cumulative exposure over decades. Plus, many people with adrenal issues have other comorbidities that might require steroid inhalers or creams or injections. It all adds to the cumulative load on the eye. The American Academy of Ophthalmology points out that risk depends on dose, duration, and potency. So while replacement patients shouldn't panic, they also shouldn't check out. You still need to be monitored.
Let's talk about that cumulative load. You mentioned inhalers and creams. I think a lot of people assume, oh, it's just a nasal spray for my allergies. It doesn't count. Does route matter?
Route matters immensely. The closer the steroid is to the eye, the higher the risk. So steroid eye drops, highest risk. But systemic absorption, meaning how much drug gets into your bloodstream and travels to the eye, happens with almost all forms. High-dose oral steroids like prednisone are a major culprit because they flood the whole system. Inhaled steroids for asthma have a lower risk, but high doses over many years can still contribute. Even skin creams, if used on the face near the eyelids, can raise eye pressure.
Wow. Okay, so it's not just the pills, it's the total package. Now, I want to pivot to something a bit more obscure but relevant. I've heard whispers about fluid behind the retina. Is that a real thing or just internet rumor?
It is very real. It's called central serous chorioretinopathy, or CSC. It's basically a blister of fluid that forms under the retina, causing distorted vision. Straight lines might look wavy, or you might see a blurry spot in the center of your vision. The American Academy of Ophthalmology has published literature linking systemic corticosteroid use to CSC. It's less common than cataracts or glaucoma, but it's another reason why any sudden vision change needs a professional look, not just a wait-and-see approach.
So we've established the risks. It's heavy. But let's flip the script to agency. How do we hold this fear gently, as the article suggests? Because knowing all this could make someone want to never take their meds again, which we know is fatal for AI.
Right. We cannot stop the meds, so we have to embrace aggressive monitoring. This is where you take your power back. Monitoring changes the outcome. If you catch intraocular pressure rising early, you can treat it with eye drops to lower the pressure before it kills the nerve. You can prevent the blindness.
What does a steroid-aware eye exam actually look like? Is it just reading the letters on the chart?
No, reading the letters, visual acuity, is just the surface. A real exam for a steroid user needs 3 key things. 1, intraocular pressure measurement. That's the puff of air test or the blue light probe. 2. A dilated eye exam. They have to widen the pupil to look at the lens for those specific cataracts and, crucially, to look at the optic nerve head for damage. And 3. If there's any suspicion, a visual field test or an OCT scan, which is like an ultrasound for the back of the eye.
I love that term, steroid aware. It implies that the patient needs to advocate for themselves. You can't just walk into a strip mall optometrist and assume they know your medical history.
100%. You have to walk in and say, I have adrenal insufficiency. I am on long-term corticosteroid replacement. I need you to check my pressures and my optic nerve specifically. You are not being difficult. You are being smart. FDA prescribing information for prednisone specifically warns about these risks and recommends monitoring. You are just following the label.
That is so empowering. It shifts the dynamic from, I hope they find nothing, to, we are actively looking so we can handle it. But I want to touch on the emotional side of this. For people with chronic illness, there is this fatigue. It feels unfair. I have this disease, I take the medicine, and now the medicine might hurt me? How do we reconcile that?
It is unfair, and I think acknowledging that anger is healthy. You can be grateful that hydrocortisone keeps you alive and simultaneously furious that it threatens your sight. Those two feelings can coexist. But the antidote to the anxiety is data. When you go for that exam, you replace "what if" with "here is what is happening right now." If your pressure is normal today, you can let go of that specific worry for the next 6 months. You buy yourself peace of mind.
That's a beautiful way to put it, replacing what if with what is. Before we wrap up, are there any emergency signs? We talked about the slow creep of glaucoma, but is there anything that screams, go to the ER right now?
Yes, while most steroid glaucoma is slow and painless, there is a rare type called angle closure glaucoma that is an emergency. The National Eye Institute lists symptoms like sudden intense eye pain, nausea, vomiting, red eye, and sudden blurred vision. If you have that combo, you do not wait for an appointment. You go to the ER. That is a sight-saving emergency.
Okay, that's a clear red flag to watch for. Intense pain plus nausea. Got it. So, Alex, if we zoom out, what is the main takeaway for someone listening who is clutching their pill bottle a little tighter right now?
The takeaway is that your eyes are resilient, and medicine has advanced incredible amounts. We have drops to lower pressure. We have lasers. We have surgeries to replace lenses. A diagnosis of steroid-induced ocular hypertension is not a diagnosis of blindness. It's a call to action. You have tools. Use them. Schedule the appointment.
A call to action, not a sentence. I think that's exactly what this community needs to hear. We deal with so much uncertainty, but this is one area where we can actually take control. Thank you, Alex, for breaking this down with such clarity.
My pleasure. It's about staying safe and staying sane.
And to everyone listening, if you know someone navigating long-term steroids, whether for Addison's, asthma, or autoimmune issues, send them this episode. Knowledge is the best way to lower the fear. Take care of your eyes, and we'll catch you next time.